Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I will be discussing Internal Medicine Competency 1.13 Blood Pressure Measurement and Interpretation in Heart Disease. So let us start. Blood pressure assessment is the most frequently performed and most frequently incorrectly performed clinical procedure. So this is something you should remember. This is one of the most frequent incorrectly measured clinical procedure. So today we'll be discussing on how to measure the blood pressure and how to interpret it in various heart diseases. So patient preparation is very important. The patient should be taking rest for the last 5 minutes, should not have taken coffee or smoking. Patient should not be talking during the assessment, etc. And I will demonstrate how it is to be taken in another session. So just remember, patient should be resting for more than 5 minutes, arm at heart level and the correct size of the cuff. If the cuff size is small, the BP can be spuriously recorded as elevated. So inappropriate cuff size is the commonest cause of erroneous blood pressure. Remember this. Second is always do the palpatory method. Why should you do the palpatory method? Because there is something called auscultatory gap. For example, when you do a auscultatory method of recording the blood pressure, the coraco sounds will appear, then it may disappear for some time, and then again it may reappear. So it will be like this. So suppose the systolic BP is 200. You will get the initial sound, then the coraco sounds will disappear for some time, it will reappear. So what will happen? You are likely to miss this gap, and this is called the auscultatory gap. So that is why you always check the palpatory method and then only go for the auscultatory method. So auscultatory method, you take the appearance of the coraco sound as the phase 1 as the systolic BP, and disappearance of the coraco sound, phase 5 is taken as the diastolic BP, except in aortic regurgitation. In aortic regurgitation, usually we take the phase 4 as the diastolic BP because the BP may be, the coraco sounds may be heard till late. So how will you record the BP in aortic regurgitation? So there's an example, the systolic BP is 170 and the phase 4 is 40, write 40, 0. So this is how you record the blood pressure. So remember, in aortic regurgitation, it is the phase 4 is taken as the diastolic BP. Diastolic pressure is taken at disappearance of the sound, that is phase 5 in normal cases. Okay, now we look into blood pressure in various heart diseases. So what is the typical blood pressure pattern in heart failure? In heart failure, usually the BP is normal in the early stages, or when the sympathetic activation is there, the BP can be little elevated. In advanced heart failure, the BP comes down, systolic BP comes down, and the pulse pressure becomes narrow. So this is another thing you should remember, that is in advanced heart failure, hypotension reflects reduced cardiac output and it is a poor prognostic sign. So low BP, tachycardia and cold extremities, it is suggestive of cardiogenic shock. But again remember, preserved BP does not exclude heart failure. That should also be kept in mind. So heart failure may exist with normal blood pressure. Hope this point is clear. So now one MCQ question. A patient with a dilated cardiomyopathy has BP 90/60. This most likely indicates, what do you think? The systolic BP is low. It is due to reduced stroke volume. As we know, the blood pressure depends upon the stroke volume. In heart failure, the heart is unable to pump blood into the aorta. So what happens? Naturally, the systolic BP comes down. So in heart failure, systolic BP comes down. It is due to reduced stroke volume. Now going to what is the blood pressure in various valvular heart diseases. Many times, even before auscultation, we'll be able to identify the valvular lesion by looking at the pulse and blood pressure. Last time we discussed about the pulse in various valvular lesions. So let us take first aortic regurgitation. In aortic regurgitation, what happens? So this is the aorta. Aortic regurgitation, the blood which is ejected is part is coming back to left ventricle. So what happens? The stroke volume is increased. So systolic BP is affected by increase in the stroke volume or reduce in the stroke volume. So what happens? Increased stroke volume means more amount of blood is the Starling slow contraction. The heart is better contraction initially. So what happens? The systolic BP increases. That is why in aortic regurgitation you get a high systolic BP somewhere in the range of something like 170 and diastolic BP will be low 60. So wide pulse pressure is characteristic of aortic regurgitation. And as we know, the pulse pressure is the difference between the systolic and diastolic pressure. So the question is, which BP pattern is typical of severe AR? The systolic BP will be high. So the correct answer is C, 160, 50. It may not be 160. Only thing I am trying to highlight is the increase in the pulse pressure. Hope this point is clear. Then we look into what happens in aortic stenosis. In aortic stenosis, the stroke volume is low. So again, take the heart. So the aortic valve is narrow. So ventricle has the blood is being forced into the aorta. Stroke volume is less. So what happens? The systolic BP will be naturally low. So systolic BP is lower in aortic stenosis. So low systolic can occur and narrow pulse pressure. That's natural. So that is, so here you in aortic stenosis the pulses parvus et tardus, systolic BP is low. Now in severe in mitral valve disease, what happens? Most often the BP is normal. Low BP suggests not valvular disease but low cardiac output or low LV function in mitral valve disease. So mitral valve disease BP is usually normal. Low BP suggests heart failure or patient with a heart atrial fibrillation. You may get a low blood pressure. So blood pressure changes in mitral valve disease reflect ventricular function. So it is a function of the ventricles than the valve function itself. Hope you understood this point. Then now you look into what is the blood pressure in cardiac tamponade. So what is cardiac tamponade? Cardiac tamponade is something in the pericardium which is affecting the filling of the ventricle. So suppose there is a cardiac tamponade, there is a pericardial fluid or pericardial effusion produces defective ventricular filling. So in such condition, the characteristic finding that you get is called pulsus paradoxus. So what is pulsus paradoxus? Pulsus paradoxus is actually, then there is nothing paradoxical. It is an exacerbation of what is happening normally. During inspiration, the blood pressure comes down. If it is more than 10 millimeters of mercury, it is called pulsus paradoxus. Let us look what is the mechanism. So during inspiration, blood comes to the right side of the heart. So the right ventricular filling pressure increases. This will produce a shifting of the septum to the left ventricular side. Did you understand? So inspiration, there is RV filling, septum shifts towards the left side. So this produces decrease in the stroke volume. As the left ventricular filling is impaired, especially when there is a fluid in the pericardium. So stroke volume decreases, and so this leads on to decreased systolic blood pressure during inspiration. So pulsus paradoxus often reflects ventricular interdependence. So even though we say right ventricle and left ventricle, right heart and left heart, they are the septum is common. Hope this point is clear. So now we go take one MCQ. Pulsus paradoxus classically seen in. The answer is obvious, is cardiac tamponade. So you can sometimes get in the COPD exacerbation also. So the classical condition is the cardiac tamponade. Today we have understood or learned how to take the blood pressure, what is the significance of blood pressure in heart failure, valvular diseases, and cardiac tamponade.